Okay, right. Well, thanks for joining us today. So Mahua and I are going to share this presentation. I'm going to provide a bit of an introduction to what we did, and then Mahua will go into detail on the models. So this was a review we conducted well some time ago now. And it's on the Chorus website, the review itself. It was done by Natalie, who led the search, Mahua, and me. So the objectives of this review, it was really sort of to provide some background for Chorus, given that there's so much focus on primary care and NCDs in Chorus. So the objectives of the review were firstly to do a rapid review of models that have incorporated the management and the prevention of NCDs into primary care, with a focus on LMICs, and see what's in the literature. And secondly, to document the evidence that comes from those studies of the effectiveness and, if possible, the cost effectiveness of these approaches. As you'll see, particularly the cost effectiveness is really quite limited in the studies that we looked at. So I think we would describe this as a reasonably systematic review without being a systematic review. The three of us searched a series of the usual academic databases, including Global Health, Medline, and a few others. The literature was then screened in Rayan by two researchers, Mahua and myself. We each took 50% of the extracted articles, and then 20% were double screened. Initially we extracted just over 2,700 publications, and the final review looked at 97 articles. In terms of where those studies are situated, well, there's a whole range of countries. Just bear with me a minute. In terms of single country studies, the main countries represented were India, South Africa, and Nigeria. And then there were studies from a range of other countries, as you can see. There were also a number of multi-country studies. Often the multi-country studies were more about the initial development of a model rather than the actual implementation of the NCD models. Most of the studies have been published quite recently, and this then maybe is a reason for the types of evidence that have been produced. So 96% of them were published since 2010. So there's quite an influx of literature since 2010. In terms of the diseases covered, there was a huge focus on mental health. So mental health accounts actually for about 38% of all the studies. Some of the studies focused much more generally on introducing NCDs into care. Most of those studies were not evaluated, so they were general models that were introduced, but they weren't evaluated because as you can imagine, the outcomes are so varied and complex to evaluate. And then 16%, and this is maybe has particular relevance for Chorus, 16% of the studies focused on cardiovascular disease, hypertension, and also diabetes. The studies used a huge range of different evaluative methods. 23 of them were basically about the creation of models, so they weren't evaluated at all. There were also 17 reviews of various types, including systematic reviews. Then in terms of actual evaluative methods used, I would say 14 used what we might describe as rigorous evaluative techniques. So either trials, quasi-experimental techniques, such as interactive time series that we're familiar with, and also before and after studies with comparison groups. So there are 14 of those. And then other studies used a range of other arguably less rigorous techniques in the evaluation of the impact. There are also quite a few mixed methods and qualitative evaluations. Unsurprisingly, 17 of the models, the studies, basically adapted the WHO PEN package. So the PEN package is, as we all know, is the package of essential non-communicable disease interventions developed by WHO. 17 of the studies either adapted the PEN package, and another 5 of the studies took the PEN package and then added other interventions. I guess because the PEN package has been around for quite a long time now, the studies that looked at the PEN package generally had the best quality evidence, either trial data or other rigorous evaluative designs. There were PEN interventions evaluated in the literature in a range of countries, including Ghana, Tajikistan, Pakistan, which includes the COMDIS interventions, which many of you, of course, were involved in or familiar with, and also Bhutan and DRC. There were two in the evaluation of the PEN models. There were two economic evaluations. In fact, the only economic evaluations we found in the whole study. One was in Indonesia, which was all about targeting cardiovascular disease management at the over 40s. In addition to the PEN package, there were a whole range of other models, which I'm going to ask Mahua to introduce now. I've just lost my screen. I'm sorry. So I'm talking blind at the moment, but hopefully you could see this. Mahua, do you want to take over talking about the detailed description of the models? And I'll try and get my screens back.
Thank you, Tim. Thank you, and welcome to you all. A very good morning. Like Tim said, we are going to present the findings of a rapid review that looks at the various effective models that have been used for NCD care in LMIC context. And he did mention that it was done quite a few months ago, not a few, many months ago. So please bear with us while we are trying to put it all together and present it in front of you. So Tim went through all the details around the methods that were used, the words the keywords that were used, the kind of studies that were included in our review. He also summarized the PEN package for NCD care and the studies that were found on them. I am going to talk to you about the other models of other effective models that have been used for NCD care and prevention, and there are many. What I've tried to do here is club them under the ones who are, which draw from one basic model. For example, the stepped care model, which look at particularly mental health needs and mental health priorities when we talk about the NCD package of care, while the rest are actually looking at NCD-related, conditions and models that have been delivered in many countries to address those needs. Tim, can we go to the next slide, please?
So you can still see my slides, can you?
Yes, I do. I can.
I just can't see anything. But
sorry about that.
That's all right.
Thank you. So the first model that we are going to talk about here is the stepped care intervention model. Now, this is mostly used to address the mental health needs in primary care settings. The top priorities for this model has been to maximize utilization of available personnel and reduce the cost of management. It emphasizes that while simple psychological interventions may be provided to all the participants by trained non-medical personnel, severe cases are treated or prescribed medication by medical personnel and referral to mental health specialists where required. Now, the WHO Mental Health Gap Project also adopted the stepped care approach in Nigeria. A trial of the stepped care was undertaken in Nigeria, demonstrating significant improvements in mental health outcomes. So the next model drawing from the stepped care model is the MHGAP project. Tim, can we have the next slide, please? Thank you. So the MHGAP model has been developed by the WHO as a roadmap for governments in low middle income context to implement comprehensive mental health services, reform that will address the challenges that hinder effective provision of care to those in need. The core components include training of general PHC providers in the MHGAP or adapted version of MHGAP. And the second component revolves around steps that will enhance patient care at the level of service delivery. Now, the word that is mentioned here is adapted version. And I think the key word for the MHGAP project was the contextualization of the WHO guideline and the stepped care. So whatever the model is around stepped care and the guideline of WHO it had to be adapted to whatever the local needs are, the local priorities are, and the local context is. The objective of the program was designed to assist non-specialists to recognize and offer evidence-based treatment to persons with one of the 9 priority mental, neurological, and substance use disorders. In terms of the limitations, it was really difficult to ensure that sufficient specialists are available to provide training to non-specialists in a resource-constrained LMIC context. And, this doesn't come as a surprise. A before and after study was also undertaken in Nigeria, where this particular model was implemented. It was found that there were improvements in worker knowledge and an increase in the use of services. But of course, the limitation was that it was difficult to find people who are motivated enough and available to do the training, the specialized workers. The next model here that we have is the PRIME model. Tim, the next slide, please. So this particular model aimed to generate evidence on the implementation and scaling up of integrated packages of care for priority mental disorders in primary and maternal healthcare context in Ethiopia, India, Nepal, South Africa, and Uganda. It was about integrating mental health into primary care at 3 levels of the health system: the healthcare organization, the health facility, and of course, the community. There was a strong emphasis on capacity building and the translation of research findings into policy and practice, because one of the major aims was to generate that evidence with a view to reduce inequalities and meeting the needs of vulnerable populations, particularly women and people living in poverty. This was evaluated, and it seemed that it was an effective intervention in the public sector primary care clinics, particularly in India. The next slide, please, Tim. Now, we've been talking about the stepped care model and the projects that have been based on that model. The next model that we are going to talk about here is the chronic care model that was developed in the 1990s by Wagner. Now, this particular model emphasizes a number of elements of integrated care for NCDs, crucially around providing support to patients and carers to enable care in community and home settings. For example, support to enable self-management of illness. The whole emphasis of this model is around providing home-based care, or closer to home care, as they say. The emphasis was to provide decision support to providers through training and improved information systems to enable them to better meet the needs of the patients. This particular model originated in high-income countries, and I think it originated in the UK, but has been used in some low-middle-income contexts as well, including South Africa and Malaysia. Now, you would see that there is not a statement on the effectiveness of the model in a few slides. And as Tim has already mentioned, because these models have been recent, there hasn't been a lot of rigorous evaluation of these models, and therefore a lack of data, a lack of evidence around how effective they are actually. The next model that we have here is the collaborative care model. It talks about integrated care approach to mental illness and linked physical NCDs that vests the overall responsibility of the program with the primary care physician, supported by case manager and a mental health professional at the PHC level. They have various, this particular model has various interlinked components that includes capacity strengthening or building, strong referral systems, anti-stigma initiatives, and lifestyle change adapted to the local socio-cultural contexts. It also talks about specialist community models, whereby psychologists and general practitioners supported by specialists are trained within the specialist programs to provide community support and treatment for those with several mental disorders. Now, this particular approach or model has been tested in several low-middle-income countries and high-income settings. The countries that it has been tested in include Jamaica, Chile, and Nicaragua. The next slide, please, Tim. This particular model of collaborative care identifies key actors because it's all about collaboration across the different people, the different service providers, and also collaboration between the different health system levels. It identifies key actors and essential elements of health system that encourage high quality chronic disease care, the community, the health system, the self-management support, delivery system design, decision support, and clinical information systems. The enabling factors of this particular care model have been the quality of communication and building long-standing relationships between health professionals and patients to provide support of self-management, decentralization of the services associated with better health outcomes as services and care is made available closer to home and more easily accessible, the availability of essential medicines, diagnostics, and trained personnel providing the essential package of care, and strong coordination between the multiple care providers. So these have been the highlights of this particular model. And we can clearly see that there are interlinkages between what we just discussed around the chronic care model, where there is more, support around self-management of illnesses and providing care closer to home. The next model that we have here is a model called the Wonka model. And this one is again based on the collaborative approach, which considers it essential to address challenges facing mental health services, delivery challenges. It promotes the adoption of the psychosocial model of holistic care, reflecting the importance of mental health for individual well-being. 7 domains have been identified as the core competencies of the health workers or the family doctors that are working on this particular model in mental health, delivering mental health care, namely values, communication skills, assessments, management, collaboration and referral, and reflective practices. This model was developed relatively recently, and therefore no evaluation was found in the reviewed studies. The next model, again, a mental health model, is the mental health scale-up, the MHSUN model. The objectives of this particular model was to develop a model of integration of mental health into primary care in Nigeria that is evidence-based, appropriate to the local context, feasible, accessible, acceptable to those who are using the services, and also to the ones who are providing the service. One of the objectives of the model was also to evaluate the service, focusing particularly on key processes of successful implementation, as well as broad outcomes such as coverage, efficacy, and user acceptability. And to use the results to advocate for service reform and investment by presenting convincing evidence in an accessible and persuasive format to key decision makers. Now, the primary and secondary services under this model integrated to form the basic package of mental health care based on MHGAP intervention guide that we discussed a few slides before. The capacity building of local health practitioners was provided using those guidelines that was provided in the MHGAP guide. There was ongoing support and skills development of practitioners, including monthly supervision, support for complex cases through outreach visits. Governance was also provided throughout the established health system structures with particular attention to mental health aspects. And of course, the health systems approach was taken to ensure all relevant components that contribute to successful services will be addressed, negotiating use of appropriate physical infrastructure, health financing, health information system, medication availability and interaction between the different levels of services, that is referral and supervision. Community engagement was also deemed essential for ensuring that social integration and providing social support, which was one of the pillars for this particular model that was used in Nigeria. Now, all these models that I've been talking about have been looking at mental health challenges in these countries where they've been implemented. Now, the models that I'm now going to talk about are around the non-mental health related diseases that we find in the NCD basket. There are various that have been found in our study. One of those is called integrated care pathways. Tim, can we have the next slide, please? Thank you. Now, this particular model was implemented in Malaysia and focused on the management of post-stroke patients. It was designed to act as a catalyst to improve the quality of care, service provision, and delivery in low-resource settings. It was structured around multidisciplinary care plans for patients who need care management over an extended time period. It included clear planning on the structure of care, coordination across providers, and evidence-based care and standardization. The reviewed study describes the development of the model, and there is no evaluation of impact, although a trial was planned. So again, there's no particular evaluation from this particular model that was reviewed for the purpose of this study. The next model that we're going to talk about is the Integrated Chronic Disease Management Model, which is also called the ICDM. It is based on the principle of the chronic care model, an innovative care of chronic conditions framework to improve patient care and health outcomes. It aims to provide a comprehensive chronic disease management that reduces unnecessary healthcare utilization and promotes self-management amongst the patients. The patients who are incorporated in this particular model include adults and children with chronic communicable diseases, that is HIV, AIDS, and tuberculosis, and non-communicable diseases, which includes hypertension, diabetes, asthma, chronic obstructive pulmonary disease, mental health, and epilepsy diseases. There are other models as well, apart from these, basic models around ICM and ICDM. The other models include, Tim, can we have the next slide, please? It's one of the models is called the Pro-Mujer integrated model. I don't know whether I'm pronouncing it the right way. Now, please excuse me for that. This particular model integrates healthcare into a microfinance program. Very interesting. Focusing on early intervention through health education, facilitating access to primary health services, allowing for screening and outreach with populations of women at high risk of NCDs. So clearly, in this particular model, there are some keywords that are used. It's a microfinance program, and the target group is women who are at high risk of NCDs. A case study of the operation of this particular model was done in the 5 countries. In 5 countries, suggested that the intervention was associated with substantial provision of preventive care. There is, however, no comparison with non-intervention areas or substantive time series analysis to understand the trends in care over time. The next model that we have here is the CASALUD model, which is a comprehensive primary healthcare model that enables proactive prevention and disease management throughout the continuum of care, using innovative technologies and a patient-centered approach. Now, the words that are in bold are the keywords for this particular model, and I think these are the ones also that sort of distinguishes it from the other models that we've discussed. This particular model was developed and financed through the Carlos Slim Foundation, and neither the public healthcare system nor its users, beneficiaries, incurred any additional cost. It operated through 5-pillar intervention, with each pillar having specific technologies that allowed its implementation in primary health clinics. No trials or control quasi-experimental studies of this particular model were found. A recent retrospective observational study found that those treated in CASALUD model were under this particular model were more likely to have the diabetes controlled. Can we have the next slide, please, Tim? Now, this model, the Prevenimis, it is a comprehensive package of preventive services, a set of practices directed towards health promotion, nutrition, reproductive health, and the prevention control and early detection of selected diseases. It shows an important increase in coverage for the principal components of the program. Yet evaluation of the impact of this program revealed increases in rates of type 2 diabetes and hypertension. The only positive impact found was a reduction in mortality rates for cervical and breast cancers, and this was associated with early treatment and detection. I mean, because the emphasis of this particular model was on, the preventive services and early detection of these particular diseases. Now, this particular model was incorporated as a primary care-based integrated program in one of the largest healthcare providers in 2002 in Mexico. The aim of this model was to reduce the burden of disease through preventive services, as we've already talked about. And there has not been much evidence on how well this particular model has fared. The other model that we have here is called the M-WellCare intervention, which is an intervention that is a mobile health system, incorporating integrated management of chronic conditions, hypertension and diabetes, evidence-based clinical decision support system, longitudinal health data, and automated short messaging services to reinforce compliance to drug intake and follow-up visit used by nurses at primary healthcare settings in India. Now, it was developed in 2 stages, development of the clinical algorithms, and the second stage was about development of the mental health application in itself. It aimed to address the gaps of unusual care and optimize its utility, acceptability, and feasibility. However, RCT in India found no significant difference between the intervention and the control areas across a range of cardiovascular outcomes. Now, I know as part of the NCD care package and prevention package, a lot of us are thinking about using these digital technologies, and I think a careful look at this particular model can give us ideas about what to do and what not to do if you are thinking of adapting a digital, for example, a mobile M-Health system to get better services and better care for people at the community level. The next model that we have here is the Chetna NCD program, which was established in April 2017 in the East Champaran district of the state of Bihar, which borders Nepal. This project aimed to raise awareness of NCDs, particularly diabetes, hypertension, and cancer in the population, and among other stakeholders, including primary healthcare providers working in government, primary healthcare centers, and sub-health centers. It also aims to provide screening for hypertension, diabetes, and oral cancer to facilitate the provision of appropriate and affordable NCD management and to provide holistic palliative care to those with advanced diseases. Now, when I was reading this paper, I also checked, if I could find any other substantial evidence. And I found a website of the Duncan Hospital in Bihar, who have actually adopted this particular module, the Chetna module. And they have very positive case studies talking about how effective this particular program has been in early detection of oral cancers particularly, and also how the program has supported patients and their families in treatment of oral cancers, especially talking about the poor, vulnerable people in the community, and how they have been instrumental in making sure that these patients who are in that advanced in their advanced stages of cancer treatment are able to access palliative services provided by the health systems. The kind of strategies that they have used include counseling, inpatient services, OPD services, screening camps, capacity building and awareness, networking and advocacy with government officers, establishment of wellness centers, and collaborations with faith-based organizations. So, of course, a lot of working with various actors that are so active at the community level. The next model that we have here is the TASH, which is the task shifting for hypertension model. According to the WHO, this particular model is a process of delegation whereby tasks are moved when appropriate to less specialized health workers. And I can see that there is an overlap with the models that we discussed right at the beginning of my set of slides, where we were talking about specialized health workers training the non-specialized ones so that they can deliver care at the community level as the first point of contact. Task shift from physicians to allied healthcare professionals in primary care appears to increase service provision and cost effectiveness of areas lacking healthcare resources and personnels. Now, in this particular model, there was a clear importance given to leadership, access to resources, and educational knowledge of hypertension management that were deemed very important and were seen as key factors for success. This particular model was used in Ghana, and a trial was completed where this program was aimed at mitigating the burden of hypertension in the Kumasi area, the Ashanti region of Ghana. As part of the study protocol, nurses from 32 district hospitals and community health centers randomized to intervention and control groups received training involved in the WHO PEN package. But despite the potential for task-shifting interventions to mitigate the NCD epidemic in LMIC context, their effectiveness has, again, not been very widely evaluated. There have been some limitations, on the other hand, of this particular model, the TASH model, that have been identified in the trial, and that includes the risk of overburdening primary care staff, where there are often already shortages, excess expectations that cannot be met given available local resources, and often evident lack of supervision to ensure the work boundaries are identified and maintained. Task shifting was definitely identified as a cost-effective and a stopgap approach, and it has been applied in multiple LMIC contexts, but have some reported barriers, particularly in the when we talk about the lack of regulations for those who are trained, inconsistent approaches while training, poor employment practices and salaries for those that are given new tasks, and often inadequate supporting infrastructure, for example, equipments, space to exercise the shifted tasks. So these were the major models that we came across when we were conducting our study. And clearly there have been a few consistent cross-cutting themes that have been across these models that have been used for NCD care and prevention. Now, a consistent theme that we could see was clearly an emphasis on improving the linkages between the community and the primary provision, and also the higher levels of care. The key components included linking primary levels to tertiary care with clear guidelines, engagement with community, training and supervision of health workers, building support mechanisms within the community settings that are adapted to the local the local sociocultural context. The next slide, please. Tim, thank you. It also included things like raising awareness, reducing stigma about the availability and accessibility of low-cost, high-quality service in the general population, and more specifically in the target population. It was the models emphasized on reducing inequality in service access at relatively low cost, encouraging collaborative working across levels of care, across various actors to facilitate a more rapid referral and reduce fragmentation across the various services. The next slide, please, Tim. So in conclusion, I think it would be appropriate to say that for integration of, for any integration package that we are looking at for NCD, it should clearly look at, it should start from the bottom where we think about how effective is the leadership, management and governance that is there, at the local level and at the levels higher. What are the institutional structures, the resources, and the support that is available? For example, we are looking at task shifting, and if we are not able to provide the space for training, for example, or if we are not able to provide, the workload or incentives to the people who are taking, newer roles, then how would this particular model work? The other component that is very key here is also the availability of motivated staff. Like we are thinking about providing home-based care or self-management of illnesses. We are talking about task shifting. Now, if we are not able to get those health workers who are motivated enough and available enough, who can go into the communities, train these people about how could they self-manage their illnesses, how would any sort of integration for NCD model, how will any model be effective if we do not take care of these components? There has to be coordination, collaboration, and communication, effective communication between the different levels. We are talking about coordinating the actions of various actors. We are talking about collaborating with different actors. We are thinking about coordination and collaboration between the different levels of care. But what if there is no effective communication between these levels? How would a model of integration work in that context? And of course, all of this has to be around patient-centered care, which is the key word, to make these services, the preventive services, the treatment services, being available, accessible to the patients, to the people in the communities. So for me, I think these were the key words that emerged from the review, and which would really help us think through what could be the key components of any package that looks at integrating the basic services for NCD prevention and care. Sorry, I think this was the only slide that had a little bit of color in the whole presentation. I'm so not very creative with my slides. I'm sorry about that. The next slide that we have, Tim, can we have the next slide, is the concluding slide. And here, I would just like to say that we are lucky that in this group, there are these countries where these studies have been conducted, and we have partners from those countries. Maybe, what we presented was the theory part of it, what we have studied in those papers that we've reviewed. You might have, first-hand experience of implementing these particular models in your contexts. And I'm sure we'll have, you'll have lots to share. So Tim, I hand it over to you to do the concluding remark on this presentation. But thank you from my side.
Okay, yeah, sorry, my system's playing up. Thanks very much, Mahua. Yeah, I think what came out of the review, as you will have seen from what Mahua said, is that there are huge numbers of models around. Many of them are still being implemented. It's a relatively new field, maybe. The models that are best evaluated I think are those with single interventions, particularly some of the cardiovascular disease interventions, so very relevant to CHORUS. Some of the interventions for hypertension and diabetes, quite strong evaluations in some cases, though where the more general interventions less well evaluated. There's some good evaluation of some of the mental health interventions, although often those are not so much primary outcomes. They're sort of secondary effects, or how to do with how well tests were how well tests were introduced, or how much service was provided to populations. I think the comments that Mahua made on the task shifting were particularly relevant across the board, actually. A lot of the papers that we looked at emphasised the difficulties in, or the caution that is needed in pushing more of the tasks onto primary care centres and away from specialist care. And a number of the studies we looked at reported difficulties particularly in resourcing that task shifting. So suddenly you're pushing more emphasis onto primary care doctors and nurses and other staff, and even onto communities, and suddenly you're loading a lot more responsibility onto those communities. And again and again, the studies we looked at reflected the caution that is needed when doing that. And I guess that brings us back to the overall importance of looking at the health systems, the health system in the entirety, and making sure that any interventions are well resourced in human resource terms, in financing terms, and in other respects. Okay, I think we're probably done, and we're open to any questions. The paper is on the CHORUS website, the report is on the CHORUS website, but any questions from anyone here are welcome. Yeah, and Polly's put up the link to the paper in the chat. Helen.
Hi, Tim. Hi, Mahua. Thanks so much for that and for all the work that's gone into the review. I think it's just got some really useful evidence. And I know that during the writing workshop in Nepal, we were kind of drawing on your, your working papers, and all those references are super useful for everybody. So just as a reminder, for everybody to have a look at the references in them and draw on those in your discussion parts of all the papers that are coming together on the needs assessment papers that are being written. I just wondered, because a lot of the teams are developing intervention materials at the moment, and I wondered if any of the models that you came across kind of had links to the actual materials that they were using. Referral forms, training packages, training slides, anything like that that could actually be really helpful to teams as they put together the intervention materials.
I'm sure there would be some, Helen, but then for that I would have to go back to a few of those papers. And if there's any particular team who definitely would like to look at those materials, I mean, if there's a particular model that they are interested in and they're developing their intervention, and if they could just write to me, and then I could just be very specific in my search and I could find it out and I can send it to the team, and that's okay.
Can I ask one more question? It sounds like none of the studies looked at, because obviously there's a bit of a theme emerging in CHORUS of working with private pharmacies, with informal providers, as sort of part of these interventions, particularly around hypertension and diabetes, or even, in Bangladesh example with NGO clinics. So did any of the studies look at kind of non-public sector providers?
I think there are certainly some of the studies looking at NGO providers, and I think it almost inevitably. I think from memory, I don't think there are any that were looking at interventions with certainly not the informal sector, and I don't think with pharmacies.
Okay.
Yeah, I agree. I think particularly talking about the Chetna model, that's a model that has been run by an NGO, and the one also in Mexico, I think they have been run by organizations with collaborations with NGOs, microfinancing, which are working on microfinancing with women.
Yeah.
So those were the only ones that have spoken at length about the collaboration with those actors. But as Tim said, private sector hasn't been mentioned many times in these papers.
Yeah, that's helpful to know.
I guess it adds another layer of complexity when you're contracting with other organizations. And as we've observed, I think the best evaluations are the ones that have relatively simple interventions. And as soon as you add another layer of complexity, it's important to do, but it does make the whole implementation and certainly the evaluation of the model more difficult.
And I just want to add, there's a call out from GACD looking at the management of multiple long-term conditions, which people on the call may be interested in, obviously very relevant to some of these issues. So I just put that in the chat for people.
Mahua, did you mention probably you did, but I don't remember. Did you mention the crossover between HIV care and other services? Because that was quite a common theme of some of the models, wasn't it?
Yes. I mean, I think when we were doing our data, our literature search, I think this question came up that do we really need to look at HIV/AIDS? And I think one of the primary examples of integration of care was when there was integration for HIV/AIDS, and there's a particular model that is talking about communicable diseases and non-communicable diseases and the integration of care for it. Sorry, Tim, if I answered your question.
Yeah, you have. I think you have. I think it was particularly striking, and maybe it's particularly relevant, maybe less relevant to the chorus countries actually, but particularly relevant in countries where HIV is very prevalent and where ARVs are used extensively. Suddenly, you have a captive, vulnerable population, or I mean, a captive in the sense that they've got a lot of contact with the health system, and it's possible then to introduce other interventions into the care package. Maybe it has a relevance to other types of chronic, where you've got people coming to health facilities for other chronic conditions such as TB, for instance. You have a vulnerable population that has engaging with the health system a lot, and you have the possibility then of introducing other interventions, other NCD interventions, and looking at the impact.
Yeah.
Okay, if there are no other questions, I think maybe shall we leave it there? And if you have any questions about any of the models, then Sushil's put something in the chat. Do you want to?
Well, hi, Tim.
Oh, hi. Yeah,
great.
Yeah.
Really, thank you very much for really expanding our knowledge base on primary healthcare, different model, very comprehensive. Really, I really appreciate that. This was very timely for us because the chorus, as well as in country, we have been discussing quite a lot about strengthening the traditional primary healthcare model in the context of urban area where the cities are growing, and it's pretty clear that our health systems, urban health systems, has a very poorly designed primary healthcare delivery model to date, and we are learning, and there is no specific learning has come out on looking at the characteristics of the urban, and not only the service users, but all the providers, and the complexity around it. Did you come across any specific reference of a specific, pilot or model which looked at primarily in urban area or in urban and rural area comparison, something like that?
That's a very good question, and something, Sushil, we should have reported on, given the focus of Chorus. And apologies for that. We did specifically look for urban models, and we found later on that we had to just extend it because there were relatively few urban models. There were 8 studies that did focus on urban areas, and we can provide you with the references for those. But most of the models tended to have mixed areas, so they were neither solely rural or solely urban. They mixed the intervention settings, but we can certainly pull out the small number of studies that only focused on urban areas, and point you towards the references.
That's great, really. That would be helpful for us. And surprisingly, yes, there is no urban specific model, considering that urban brings a different characteristics and innovation.
It does.
Our focus on that.
Yeah, it was 8 out of 97 were exclusively urban.
Right. Okay. Great.
But I guess it shows that there is value added from Chorus, doesn't it?
Yes. Yes. I think we should be thinking more on across our partner countries, how we could contribute to this knowledge gap.
Yes, absolutely. Yeah.
Great, good.
Okay, if there are no further questions, then shall we? I think we'll just coming up just past 11 o'clock here. So shall we leave it there? And if you have any questions, then do come back to either of us. Thank you very much.
Thank you.
Thank you. Great. Thank you all.
Thank you. Goodbye.
Thank you.
Thank you. Bye.
Thank you
Very much. Bye.